Hello everyone, my name is Adrian. I am one of the residents at the University of Florida, Department of Internal Medicine in Gainesville, Florida. Today I'll be presenting a case called spontaneous pneumomediastinum in a patient with myositis-associated interstitial lung disease in a phenomenon called the Macklin effect. Spontaneous pneumomediastinum is a relatively rare condition and disease process in which air is present in the mediastinum that is not caused by trauma. Therefore, if it is caused by trauma, it's secondary pneumomediastinum. Causes of spontaneous pneumomediastinum are causes such as asthma, COPD, drugs, or incessant vomiting, anything that may cause increased intrathoracic pressure or at the same time changes in the actual parenchyma of the lung. Here, interstitial lung disease is a debilitating disease that's associated with inflammatory myopathy. In rare instances, ILD can cause pneumomediastinum. And this is a case of a young patient with pretty recently diagnosed dermatomyositis that presented to the hospital for weakness and incidentally found to have pneumomediastinum. A 27-year-old man with, as I mentioned, recent diagnosis of anti-SAE dermatomyositis presented from clinic due to worsening weakness and diffuse skin lesions. He was recently diagnosed and he was started on immunosuppression with mycophenolate and was planned to start IVIG on the outpatient setting due to his pretty severe dermatomyositis. However, unfortunately, due to insurance issues, he was not able to start the IVIG. On admission, vitals were notable mainly just for mild tachycardia. The patient was on room air, resting pretty comfortably with unlabored breathing. Chest x-ray to rule out pneumonia due to the tachycardia depicted a widened mediastinum that you can see in image 1, which we will get to. Due to this incidental finding, there was concern now for air in the mediastinum. He got a CT chest followed by a CT esophagram, and the reason why he got the CT esophagram is because he had an EGD done prior, which showed ulcers. In the CT, both instances confirmed the presence of air in the mediastinum, as you can see in image 2. He was treated subsequently with 100% oxygen with resolution of his pneumomediastinum, as seen on image 3. He was also treated with IVIG in patients with improvement of his symptoms of weakness. Here are some of the images. It's a little bit difficult to note, but in image 1, you see a little bit of air in around the bronchioles as well. In image 2 here you can see pretty notably the air in the mediastinum on the CT chest. Whereas in image 3 you start seeing resolution of the widened mediastinum. And this was on right around the time he was about to discharge. He had improvement of his symptoms, generalized symptoms. So in discussion, interstitial lung disease is a known complication of myositis. It's usually associated with myositis-specific antibodies such as anti-SAE1 and anti-Jo1, which our patient had anti-SAE1. Although rare in severe forms of ILD, subpleural blebs rupture, which leads to the accumulation of air along the sheaths of the pulmonary vessels and bronchi. And this is a phenomenon that's actually called the Macklin effect. Other causes of pneumomediastinum in dermatomyositis patients have also been attributed to subpleural cyst ruptures due to the damaged alveoli. Other theories also suggest that it could be secondary to the steroids that these patients are on that weaken the alveolar wall. Treatment usually revolves around treating the underlying myositis with immunosuppression and steroids, but also, most importantly, treating the acute problem with oxygen, or 100% supplemental oxygen. So this is my case, a relatively short case. Here are my references. Thank you so much for giving me the time to talk about this interesting case, and thank you all.